Okay, Assalamu alaikum. Good afternoon, ladies and gentlemen. We'll continue. This is the live transmission from Kuwait. I'm Dr. Mohammed Kurdi. I'm an interventional cardiologist from Saudi Arabia. I'm very honored to be the anchor person for this session of live transmission. With the same theme of bifurcation, we're moving from lectures and discussion into real cases where we have a live discussion. So we're going to have a very interesting case from Kuwait. First of all, let me introduce the panelists and the experts with me on the podium. I have Dr. Khaled from Belgium. He's the procedure analyzer. We have the device expert, Dr. Ziad Ali from United States. Welcome to the Gulf area. Welcome to Dubai. The panelist on this side is Dr. Abdullah, who's a friend and a known structural interventional cardiologist from King Fahd Medical City. Dr. Adil Tash, who's a colleague and a senior cardiac surgeon, and he's the surgeon on the panelist. So we have always to consider that. Of course, at the last and not least, Dr. Mustafa Youssef, who's a known and founder of the Saudi Interventional Society. Mustafa is a private interventional cardiologist in Riyadh. We'll start the case. Are we ready? Assalamu alaikum, Shabab. Dr. Khaled, Dr. Abdullah. We have the panelists with us here and the audience. We're pleased to have you as our live case today. And there was a lot of discussion about the bifurcation in the entire day and the afternoon. And today we're going to go into a practical live case session through your interesting case to present to us today. So without delay, if you start presenting your team and then presenting the case, please.
Assalamu alaikum, Muhammad. Good afternoon, everybody. We're really glad to be back in GIS, and Abdullah and I would like to thank the GIS for inviting us again in this elegant meeting, and hopefully we can show today a case with high educational value. So what we have here is an interesting case. So I'll show you the slides because I think we need all the time in the live transmission. We'll just speed up the process here. So next slide, please. So our patient is 40 years old, a gentleman who's a smoker, and he was admitted with non-ST segment elevation MI. His past medical history: hypertension, diabetes, and he has end-stage renal disease on hemodialysis, and he has strong family history of coronary artery disease. Next slide, please. Blood results are unremarkable. LDL needs some more work. Next slide, please. He has an iodine allergy, so we prepared him with steroids and antihistamines. Next, please. And then we did coronary angiography that we'll show you in a second, the fluoroscopy. And he was having a LAD calcified disease, SERC. Next, please. We'll show you more images here. And RCA. Next. His echocardiography showed normal LV function and clearly that he has multivessel disease, and we referred him for CABG, and the patient totally refused to go for surgery. And then we decided to do multivessel PCI. Next, please. So there are questions whenever we deal with a left main bifurcation is which axis we should use and where to start in this patient specifically, because there was critical lesion in the RCA and there is left knee. And the other thing, which technique? We heard today Dr. Ziad talked about different techniques and evidence behind it, and now which technique we would use. And it's a left main disease, and the RCA was subtotally included, should we use in a mechanical circulatory support, and the role of imaging. Those are questions I would leave it for the panelists to discuss it. And let me show you the angiogram. Can you go to CAT, please? Can we show on the screen, please? We're waiting for our guys to show it. Yeah, so you can see here the spider view. You can see there is disease in the distal left knee, and proximal circumflex RT has a significant disease. Next, please. This is a caudal view which show the LAD disease. Next, please. And this is the LAD disease. And before you comment on the case, let me show you more information about the patient. I'll show you the OCT to the LAD, from the LAD to the left knee. And then I would like to hear your opinion about the approach and what would you do before we tell you what we have done. So I let this run for a second. This is from LAD to the left knee. We're using here Altrione, so usually we are used to from distal to proximal, but here it's from the left vein down to the distal. Do you see the OCT?
No, the
Can you put the
OCT,
OCT
we need to change the, yes, please.
Sure, we'll. Okay, I'm going to scroll it manually from distal to proximal.
Okay.
Sorry. And you can look at, when you want me to slow down, just tell me slow down. And this is from the LAD, you can see the calcium. And we're coming to the mid-LAD. That's the diagonal branch that we see on the fluoroscopy. And you can see more calcium there, and you'll see more calcium there, more than 2 quadrants, and now it's almost 3 quadrants calcium. And here is the bifurcation with the left knee, and this is the left knee, which is really large left knee. This is
Khaled, great. Can we just stop and just ask
No. Let me show you more of this, please. Maybe. Okay. This is the mid-LAD. Apologize. See, more calcium, tight lesion here. And this is another branch. And we're coming toward the ostium of the LAD. And this is the ostium of the LAD, is very tight. And here you can see the left knee. Now, that's all the information about the patient. We have your opinion about this patient. What would you do? Meanwhile, we'll continue to, Dr. Abdullah will proceed to do whatever we needed to do.
Okay.
And then we'll see what he has done and what's our approach.
Wonderful, Khaled. I'm going to ask our procedure analysis expert, Dr. Carlos Colette, to give us his comment first.
So we have, that's a spectacular case, and I think it's very educational. So we have a patient presented with a non-STEMI. The culprit, have we seen the angiographies, appears to be the right coronary artery. So this is the lesion that needs to be treated, let's say, first in the context of the acute event. Now let's focus on the left main, because it is a bifurcation transmission. And I think one of the first elements that we have seen is that the lesions appear to be moderate. At least that is true for the circumflex. So I think here, from the diagnostic point of view, the most important thing to start discussing the strategy is to define the significance of that lesion, particularly the option of the circumflex. For the LAD, appears to be more clear. Now we have seen the OCT, but I would like perhaps to do a pressure pull back coming from the left, from the circumflex, to be sure that that vessel needs treatment, and that might change the strategy. Now, if we move down to the disease itself, we're dealing with a bifurcation that appears to be 0-1-1. I'm not so clear with all the angulation that we have seen. I didn't see significant disease at the distal part of the left main, but osteal-LAD and osteal circ, and the lesion length at the level of the circ appeared to be very short as well. So I think that if we put all this together, I think that one of the strategies that could we think about in terms of bifurcation PCI would be to, one, consider a provisional strategy from the left main towards the LAD. And there is an important anatomical component that we have seen with the OCT, that is the difference in size. So the left main is a huge vessel, and we have seen that the LAD and the circ are smaller. So in the terms of stent selection, we should be selecting a stent that can grow onto the dimension of the left main. These are my first thoughts. I would like to make a comment on the OCT because I think I saw something very important, which is the fact that the calcium appears to be localized contralateral to the circumflex. We have to double check that. If that is the case, that increases the risk of side branch occlusion. And that has to be considered also when selecting the PCI strategy, although I would like to see the OCT with more detail.
Dr. Ziad, any comment about the devices that you will think of, and what are the stents and what's the strategy?
Well, thus far, the major device that's being used is the OCT. The OCT should be run from the LAD into the left main as well as in the circumflex into the left main. And that provides us essentially what we need to do an MLD max guided procedure. The morphology in this case, we did see some heavy calcification, but we didn't really focus on it. I would have liked to use the Ultron to actually quantify the amount of calcium that's more than 270 degrees in order to determine whether we need to do any advanced lesion preparation. And then second of all, as Carlos mentioned, you'll notice that the external elastic laminar measurement, which was quite distal, was 3.3, and there's no 3.3 millimeter stent that will get to 5.7. The closest would be 3.5, and a 3.5 Zions can get you to 5.75. So we need to be careful about picking our stent selection. It looked like it was 67 millimeters on the OCT, but I didn't really follow the strategy in terms of identifying the distal right segment at this point. So from a device point of view, I think the key features are to perform OCT both from LAD and circumflex, then determine whether you need one or two stents in each vessel, and then to determine lesion modification based on the presence of calcium.
Great. Any comment from the panelists? Dr. Abdullah?
Just want to clarify the creatinine in this patient. I saw 900 something.
Yeah.
Was that true?
Yes.
Okay.
He's an end-stage
So,
renal dialysis.
I have two comments. One is probably, in my opinion, the RCA was the culprit and should have been dealt with first. Number two is, was it really necessary to stent the left main in someone who is 40 years of age and has this advanced kidney disease? So it's just going to be a matter of time before he comes in with ISR. So in my opinion, the culprit is clearly the right, and the left main is just a bystander that can be dealt with medical therapy, at least for a few years until he's symptomatic from it, then it can be dealt with later on.
Dr. Atem?
I think, first of all, this is a young gentleman. The only real risk factor that he has is the end-stage renal disease, which now we know from a lot of registry results and studies that CABG in end-stage renal disease on dialysis patients does not have a huge impact on the risk. The other thing is that, of course, he is diabetic, three-vessel disease, left main. I think the approach to this patient or describing what are the options for this patient, maybe sometimes we tend to skip some points and explaining to this patient that the CABG is definitely superior than left main stenting and bifurcation stenting in these cases. So I think, sometimes the approach and the way we explain to the patient his options is quite important.
Absolutely. Dr. Youssef, the suggestion of starting between RCA or left system, What's your intake on that?
So I would definitely start with the right coronary artery because of the fact that it's most likely the culprit, but also because it provides me with the support required just in case something goes wrong with the left main bifurcation, and it is relatively the more straightforward of the two lesions. Now, I think more likely than not, you're obliged here, if you go the angioplasty route, to do a bifurcation to stents rather than provisional. However, to document the importance of the circ, and you've got the OCT out already, I would definitely do OCT for both the circ and the LAD to confirm the significance of the circ and the degree of narrowing as well as the morphology of the lesion itself.
Great.
Then comes the question of what approach to the bifurcation, and that's open for a lot of discussion. There is no one right way, in my opinion, for doing a bifurcation.
Wonderful. Dr. Hashmi, would you consider an MCS, a mechanical support here in this patient?
Not really, no. It's a complex case, but it's not very complex cases. So, what I will not really use any mechanical support, either balloon or impeller in this patient. But what's scary about me is it's very long left main he has, this patient, very long. And I wonder, Dr. Khaled or Dr. Abdullah, whether you are going to stent the whole left main to cover the distal lesion, or just you will take part of the left main covered and leave the others, which will increase the atherosclerotic, especially the patient is young, and I think he has significant premature atherosclerotic, which will increase in the future if we don't control it well. So I don't know what's the plan regarding this with this long left main.
Wonderful. Khaled, Abdullah, the floor is yours.
Thank you very much. Before we see Abdullah, what is his plan and what he did so far, just to answer a couple of questions. One is the sizing, and we are applying MLB max algorithm. And you can see from, can we show the OCT, guys? So the distal LAD is, if we go by the external elastic laminus 3.36 and lumen is 2.65. So it's in between 2.75 and 3. And if we go to the proximally, we are planning to land the stent into the mid left knee, which is the lumen size at 4.36. We think we need to optimize the stent that we put it there with at least 4.5. So that's regarding the sizing. Regarding what is our plan, answering the questions, Dr. Abdullah, tell us what we are going to do.
Thank you, Dr. Khaled. Thank you, GIS and chairperson and great panelists for inviting us again. First of all, I was really enjoying all the comments that you guys made regarding the case. So let me just tell you about our strategy, what we've done so far. So for left main cases, we usually like to use 7 French guide. So if you can do it through the radial, that would be great. So in which case, we are lucky we're able to get a 7 French cylinder sheath in. So that's what we have in place. And we elected to treat the RCA first because if you have the RCA patent with no obstructive disease, I believe that treating the left main becomes more safe with regards to hemodynamic stability when you're occluding the left main. In terms of our strategy, I think when we look at bifurcation, at least my simple approach to any bifurcation, do I need to keep both vessels open? This is a left main bifurcation. The answer is yes. The second question, is it a simple bifurcation or is it a complex bifurcation? If it's simple, then I can attempt a provisional stenting. And if it looks complex, then I tend to go with upfront 2-stent strategy. So our initial assessment, this appeared to be a complex bifurcation with at least 011 Medina class of bifurcation. We performed the OCT, that was our intracoronary imaging to get the best result for our patient as possible. And with regards to MCS, I don't think this is required in this case, so we are not using any mechanical circulatory support. So what we have done so far, we treated the right coronary artery. So we'll show you the right coronary artery first. This is the right coronary artery. It's a long lesion. Here's like a 3.5
we don't see it.
diameter.
We don't see it.
Oh, please make, yeah, we showed you now. So please make the fluoro on the screen. Okay, now you see
Thank
it.
you. Yes.
And so we used the 3.5/48 stent, shows the final result. And this is the final result. So now we've treated the right. Then we decided to go on the left side. So take us to the guide here. You can see from this view, we believe that the circ is, I heard discussion about being intermediate. I think from this view, we believe that it's significant, both the ostial LAD and the ostial LCX, and that was confirmed on the OCT that we have seen. The distal left main has disease, but it's not significant. Show us next image. This is the RIO codo, the same thing that shows us that the ostial LCX appears to be significant to us, as well as the proximal and ostial LAD next. And the cranial one shows the LAD has disease even in the proximal and the mid segments. And like Dr. Ziad Ali saw the OCT, the length is about 67. So we definitely need 2 overlapping stents to cover the LAD all the way to the left main. I heard the question about, do we need to cover the whole left main? Our usual practice is if the mid part is normal, we can land it in the mid segment of the LAD and it appears healthy. I think it's safer that way, because having stents covering the ostium is always at risk of damaging the stent with the guide. So what we decided to do here, we did the OCT, we got our morphology assessment, so there was calcium, like you guys noticed. Maybe we didn't give you much time to look at it, but there's definitely a lot of calcium. Some of it was superficial, some of it was deep. So we thought we would be able to deliver a shock wave. So we pre-dilated using 2.5 balloon. You can see the proximal segment is undilatable with the compliant balloon. So we went ahead and used the 3.0 shock wave. And you see it in the proximal segment was not opening, but after delivering the shocks, it was yielding. And so this is where we are right now. We also did the shock wave for the proximal LCX. So our strategy now is to use, given that we believe that this is a complex bifurcation, we plan to use two-stent strategy. Everyone is different with, comfortable with a different type of strategy, but I think the one that has the best evidence in the left main bifurcation is the DK crush technique, and that's what we're going to do. And with regards to the question, with regards to where you're going to land the stent, we're going to land it in the mid of the left main. So that's where we stand now. We did shockwave for both vessels. Now what our plan is to go ahead and pre-dilate the circ, put a stent, crush it, and keep going. So if you have any questions?
So Abdullah, as you proceed, we're going to discuss few interesting issues that you raised. The plaque modification therapy. Abdullah, what do you think? Would you use the shock wave? Would you think this is needed? Would you do something different? What was your assessment of the OCT? Do you think the shock wave was indicated? On which basis?
We saw the OCT very quickly, so I didn't really pay much attention to the calcium. But to me, I'm a liberal in terms of when to use the shock wave, especially in someone with like advanced CKD. It doesn't hurt. It probably hurt the budget, but it doesn't hurt the operator. So to me, it's very appropriate in this setting.
So hurting the budget from private practice. Would you do the shock wave, Mustafa?
So regardless of the cost, I would not use the shock wave as an initial approach to this patient. I think probably you can get away with a very simple approach. If you allow me, I have a question though, because we can't see on the angiogram very clearly. Hello, Dr. Khaled, Dr. Abdullah. Very nice to be involved in your case here.
Hello, how are you doing, my friend?
Allah ysalmak, tislam. Do you think that the ostium of the circ itself is involved? Because we can't see as clearly with the images here. How confident are you that the ostium is involved?
Well, you can't beat a good OCT image, so I can show you that.
Ostium of the circ.
Yeah, so now we're coming from the proximal circ. Go to the OCT, my dear. So in the middle is where we are now. So I'm going toward the more proximal part. And this is the circ, that's the tight lesion. And then as we go toward the left knee, you can see it is diseases back to the left knee. See that? And that's the left knee. So with OCT, clearly the ostium of the circumflex artery is diseased and need to be covered. What do you think, guys?
Yeah, sure. Definitely. So Dr. Carlos, would you like to use the shockwave in this case, or you have different thoughts?
Well, I think that we have seen several images of severe calcifications in the middle AD. So I think that one of the risks that you can encounter in this case that you spend a lot of time working the left main and then you end up with an under-expansion at the level of the middle AD that is difficult to solve. So I would go and assess a little bit more in detail, look at the arc of calcium, the thickness of the calcium at this mid portion of the LAD to decide whether a shockwave is needed. But for the way that we saw it before, it looked concentric to me and thick, so I would consider plaque modification for that calcified lesion in the LAD.
Okay. Dr. Ziad?
Yeah, I think I would have studied the OCT a little bit more carefully. I'm sure they did that, but didn't present it. So the way I do this is I go onto the morphology screen, and then I switch the calcium from 180 to 270, because 270 is really the predictor for underexpansion. When we develop the calcium CVI score for OCT, you get 2 points for 270 degrees of arc, you get 1 point for 180, you get 1 point for more than 5 millimeters in length, and you get 1 point for more than 0.5 millimeters in thickness. If you have 3 points or greater, you end up with a high likelihood of stent underexpansion. So we like using the score because it's being validated, and so I think I would have probably used that to determine whether I need to do advanced lesion prep. But it's a big artery. I think out of plaque preparation strategies, shockwave was the appropriate one, because as you saw, the tightest segment of the artery is really in the osteal lesion.
Great. Dr. Hashmi, 1 or 2 stents?
I will go for 1 stent strategy, really. For this case, I will not go for 2 stent strategies. He's young, and age is very important for me here. I want to give him more chance of 1 stent than 2 stents. Well, if I anticipate the future for this gentleman, which I wish not really, he will come again. He will come again to you, doctor, perhaps. I hope not. So I want to give him more chance. Maybe someone will debate and said he will come back if you put 1 stent and leave the osteal circ tight. He will might reinfarct or have a target vessel lesion again. But I will go simple with the professional stenting, give him chance with good risk control factors. I will dig more into his family histories, perhaps families, and find out what is the proper risk factor control. Because until now he has significant kidney disease, he's diabetic, and
but considering the osteal circ that we've seen in the OCT, would that deviate you into going into a 2 stent strategy rather than 1?
Well, my policy is always I start with a simple approach and left main approach, especially in bifurcation. I would give chance to medical treatment more than stent, because putting a stent is not treating atherosclerosis. He's a young guy, and he needs extensive medical treatment. I would trust medical treatment more sometimes. Perhaps I will go with the pre-dilatation balloon and put drug-eluting. Don't be scared that the lesion lift back is getting worse and worse. No, it's sometimes getting back, good. And we see that in a lot of DIP patients who use the DEP and their proximal epicardial arteries. Thinking in the future, I will not go hard on this patient.
Okay.
Just have a question for the group.
Ahmed, let me ask a question here.
Sure, go
Ahmed,
ahead.
this patient is planning, this patient is planning to have kidney transplantation. And my question is, if you want to treat medically, would you clear him for kidney transplantation?
I think that's an interesting question. Would an intervention actually modify the outcome of a renal or a candidate for a renal transplant? That would be an interesting. تفضل.
I think that's one of the reasons why we could have stressed, and I wanted to mention this, stressed to the patient that if you put stents, first of all, you have a big chance that you will come again with another, and that time it could be an acute event that will cause you muscle. The second thing is that you will need Plavix for a very long time. And with the kidney transplantation, we will have to stop the Plavix. The third thing is the stenting. We mentioned that the in-stent restenosis and the problems in the Plavix, and they're coming back again. So I think after CABG, there is no problem whatsoever for that patient to go for a kidney transplantation. But after a very complex stenting, I would think that the transplant teams will look at it very seriously, and he might not go for a transplant.
Khaled, we're missing all the fun that you're doing, so we're back to you, into Abdullah. So tell us what you're doing.
Abdullah is doing everything here. I'm just helping him. So he can tell us what he's doing.
Abdullah, tell us what you're doing.
He's doing the real work.
Doctor, regarding renal transplant, can I have some
what we've done
comment?
now, we have implanted the stent in the LCX, very proximal, at the takeoff of the circ proper and that small OM. And we've deployed it at 12 atmospheres in host not to get a distal edge dissection. And then we usually pull it 2 millimeters back and go high pressure. And then after that, we take a picture to make sure we don't have dissection before we crush the stent. So this looks good. Okay, go ahead. So this is another picture just to make sure. Yeah. Okay, I think it looks good, the circ stent. So what we're gonna do is we're gonna crush it. But I think the question now, do we need to post-dilate it more at this point? Or I think it's
definitely.
Maybe the panel can comment on this.
Yeah, I think, Carlos?
Yeah, perhaps to dive more into the technicality of the procedure, because now the crushing is very important at this part of the procedure. So my question is, first, what is the balloon that you have selected to crush? And what were the parameters taken from the imaging that make you select that diameter in terms of balloon to be sure that you're crushing the stent well?
Abdullah, do you hear the question?
Yeah, I heard the question. This is a really important question. So usually we crush with a stent that we can keep in the LAD. So we are using a 3.0 balloon. And then we like to do a balloon size for pot. So initial pot, just to make sure that the stent, the LCX stent is crushed all the way to the wall of the left main. That will make it less likely that the wire for recrossing get entangled between the two stent struts that are not completely opposed to the wall, and makes recrossing easier. So now we crushed it with a 3.0 that was sitting, a balloon that was sitting in the LAD. We're going to take a 4.5, which is the balloon we usually use for pot in this case. So we're going to do our initial pot just to make sure that the stent in the LCX is completely crushed to the wall to make our life easier.
So for those of you who have this, this is where the Philips device detection is fantastic. So if you turn on device detection as part of Sync Vision, you can actually see your crush. You can do the same thing with Clear Stent or Stent Viz or any of these technologies. And I feel like people don't use this enough to actually determine whether they've done a good job with the crush.
Absolutely.
If you use a 3.0, as is mentioned, the stent is going to be sticking inside still, and then you'll get a mangled stent when you put your second stent in. So this part of the procedure is extremely important.
So I think we have to highlight that the benefit of using imaging in the left main is not only to understand landing zone or to understand expansion at the end, is to define or to select better, for example, the balloon for the crush, which is a crucial step in the DK crush technique. So I think that the way they're using imaging, very dynamic to select every step of the procedure is quite important.
Thank you. We have a question from the audience.
This is a question for the panelists and also for the operators. In my practice, I like to use the mini crush technique as opposed to DK crush. First of all, there's less steps, so you kind of, it's more efficient. The second thing, what DK crush kind of emphasizes is that you optimize the side branch twice by double kissing, so it's easier to recross. But in practice, when you have large size vessels like this, it's much more efficient just to do a mini crush. Just in my experience, it's more efficient, and I'm just wondering what the panel thinks about this, as well as the operators.
I agree with you.
Mustafa?
And I think if you add on top of that imaging guidance, the whole point of the DK crush is to make sure that the struts are off of your side branch stent so you have a completely open hole. And if you use imaging guidance, whether you open the struts before or after, it really shouldn't matter. There just isn't randomized controlled trial data for that, but it certainly is a much more pragmatic approach.
Okay, guys, give us another wire, please. Give us another wire, please. Yes.
Khaled, Abdullah, do you have something for us or we continue discussing?
Yeah, actually, we're just proceeding with the steps of DK crush. So we have the stent crushed, and we did as what Dr. Ziad said. Because if the left main is big, we took a bigger balloon to make sure that stent is well crushed against the wall. Now we're going to recross into the circumflex artery, then do kissing balloon, and then stent the LAD, do part, then do kissing.
Khaled, have you heard the question from the audience? The concept of using the mini crush versus the DK crush, and what's your take on that?
Well, yeah, so I think they are not two different techniques. I mean, DK crush it's to do with double kiss balloon inflation. Mini crush is just a reflection of how much of the stent of the side branching that you are protruding. So I think in theory, yeah.
Yeah. So why
in theory?
Yeah. Go ahead.
Yeah. Go ahead.
No. Go ahead.
So in some cases you can be confident with making sure that you only have 1 millimeter of the stent of the side branch protruding. You're confident that you're covering the ostium. But the concern with the nano crush is sometimes you are not 100% from the views that you're having that you can be confident that you are covering the ostium. So to be on the safe side and not miss the ostium of the side branch, you want to have more of the stent protruding outside. So that's the main difference in my opinion.
Absolutely.
I think if we look to the data of different techniques, Dr. Ziad is there and he just presented data today. I think if we look to the big meta-analysis, when they looked into the crushed techniques, whether it's DK crush or mini crush, it's the same, basically.
I mean, Carlos, you published a meta-analysis, right, which showed that in rank order, the DK crush is the first stop, given the available evidence.
Yeah, so basically the message from the meta-analysis are two. First, when the length of the side branch is more than 10 millimeters, there is a benefit of using two-stent strategy. That's the first message. And the second one is what you said, DK crush with the available evidence appears to be the best bifurcation technique. Again, backed up by the evidence. But I fully agree that any other technique, in this particular case, I think that culotte could be an option as well. Yeah. So I think it has to be selected based on the operator experience and how comfortable he or she is with that technique.
I think, Mohammed, if you allow me, they're both equivalent with very little difference on clinical data separation. I think the most important factor is what you're comfortable and what you're used to. So if you're used to doing a mini crush and that's your technique of choice, you're probably better at it than doing a DK crush. And doing it as a regular routine, I don't think changes the clinical outcome here. So the comparative is very minimal between the two. And it boils down on what you feel more comfortable with.
But there's still the chance of missing the ostium with the mini crush and being well covered is still higher than with the DK crush.
Yeah, this is where using things like device detection can be very, very helpful, because you just get a zoomed in angiogram to be able to look at much higher resolution, and then you can eliminate the risk. I'm not a fan of nano crush, and the reason is because in a nano crush, depending upon the angulation of your bifurcation, you can have what looks like a crown, right? So when you have a crown that's sticking out and then you crush it, you can actually invaginate the stent and then get a ball of metal. That ball of metal is very hard to move because you basically imploded it. And so it's much better to come and go through the side of your stent, because that cell is much more able to be deformed than the top of your stent.
Yeah.
Absolutely, agree. Abdullah, any update?
So far we have crushed the LCX stent using a 3.0 as well as 4.5 balloon. Crushing it with the 4.5 balloon is a bit more tricky because you need to have it at the mouth of the LED, but not inside it because it's too big for the LED. So it was jumping back every time we were doing it. So we had to inflate really slowly. So, and we recrossed now after we crushed the LCX stent. And now we're trying to open the strut so we can do our first kissing balloon inflation. We tried with a 2O balloon, which didn't go through, so we're using now a smaller balloon. So these are the kind of difficulties that you might face when you are dealing with the DK crush.
So I think one of the things that perhaps can be highlighted, and the data of October was presented in the previous session, was that the benefit observed with OCT and guided bifurcations in October was following a very meticulous protocol, understanding not only pre and post OCT, but also checking the crossing of the wire by OCT.
Absolutely.
And that is, I think, one of the things that makes October a unique trial, where OCT was used again to check the cell of recrossing, and that was optimized in the case the recrossing was suboptimal. So these are things that can be thought on in terms to optimize the PCI strategy.
And just to add to that, Ultron 2.0 has bifurcation back. So you're now going to be able to, again, have 3D bifurcation and see where the wire is recrossing into the cell struts. And I'll be presenting some of that tomorrow.
Abdullah?
Yes.
So what's the next
So
now?
I
You
really
already...
like the comment about, yeah,
Go
I really
ahead.
like the comment about using the OCT. You see, we had difficulty getting the even 1.5 balloon. So one way to deal with this issue is to recross, because you might be going through a bad strut, if you like, and try to attempt and go through a different strut that might be better. But I think the best thing is to go into the main vessel, which is the LED in this case, and then pull back and try to access the stent that way, maybe through a better strut.
And this is interesting because there's conflicting data with regards to which stent strut you should cross. So if you believe John Ormiston, you do bench models, you should be crossing the distal strut. But if you leave the 3D bifurcation studies from Japan, you should be covering the proximal strut in a DK crush because you've already crushed. And so that's where the imaging helps, right? If you do the OCT, you can determine whether the metal is off the carina. And I think that's probably where some of the benefit comes from in October.
So I think that to clarify that point, I think it's a very good point. And I think that most of the bifurcations today are done using provisional approach, where you want to cross the distal cell. So provisional is you have to cross the distal cell, but for DK crush specifically, I think it's advisable to target a more proximal cell.
So Abdullah, how do we know which struts you actually crossed without using the
To be
OCT?
honest, you really can't, to be honest with you. And you know, I love the theory behind which struts you go through, but practically speaking, you want to go through the struts where you actually can deliver the balloon and finish your procedure in it. Because if you go through a strut that you really like based on the theory, but you cannot cross with the balloon, you cannot do anything, that's not really good.
So how would you
I love
keep?
the theory behind it.
How would you make it up at the end of the procedure, just to know and make sure that you have went through the proper struts?
To be honest, I aim always in the middle of the ostium of the crust stent. I find that, from a practical standpoint, that works for me the best in terms of getting a balloon delivered where I can cross, perform my kissing balloon inflation, and finish the procedure. One of the worst things in DK crush is that you finish the procedure with not being able to do a final kissing balloon inflation.
What stent platform are you using?
What's that? Sorry?
What type of stent? What stent are you using, platform-wise?
We're using a SkyPoint Zions. And SkyPoints, if we use our sizes here, the 275 stent can go up to 3.75, and the 3.5 stent can go up to 5.75. So we can post-dilate the left main with bigger balloons. Just back to which strut to cross. I think how to see it. I think if you really want to see if you're behind the first part of the stent that you want to avoid, you don't want to crush the stent at the ostium away from the wall. So what you can do is you can do the imaging enhancement, which almost now all the machines they have it. So once you are with the balloon across the stent or the vessel ostium, then you can do imaging enhancement. Okay.
If you could do that for us, that would be great. It would be a great opportunity to, once you do cross, to show where the balloon is using stent enhancement.
We'll do that. Just I'm concerned about the time. We have 12 minutes left. We need to do more steps. Let's have a 2-5 balloon.
So just to bring you up to speed, so what we did, the first time we crossed with a BMW, we couldn't deliver 1.5 balloon. I took it back, I recrossed to a different strut and tried again, it didn't work. We changed the BMW to a whisper wire and we were able to deliver the 1.5 balloon. So now we can upsize to 2.0 before we do our first kissing balloon inflation.
Great.
I humbly think that the strut discussion is a very interesting one, but applying that to practical day-to-day is really difficult.
And it will never happen.
It would never happen.
I agree.
And the strut that works is the best strut, bottom line. So.
Okay.
2-3-0. That's it.
So this is the 2.0 balloon we are able to cross, and we are dilating the struts of the LCX. Okay, so now we will be able to do our first kissing balloon inflation, 3.0 and 3.0 in the LAD and the LCX, before we proceed and deploy the 2 overlapping LAD stents.
Okay. So we're using 2 3.0 balloons, NC balloons, 3.0 by 15 trick balloons.
Okay.
And you know, this is the importance of using a 7 French guide in the left main. Moving these balloons in and out can be challenging in a 6 French guide. And you might lose your wire that you worked really hard to cross with. And you know, speaking of the strategy, which 2-stent strategy to use, I think use the one you're comfortable with, but the most important thing, you have to do it right without any shortcuts. So regardless of what you're using, you have to do it right and follow the proper steps to make sure you get good results for your patients.
Okay, let's have the...
So now we parked a 3.0 balloon in the LCX, and now we're getting the other balloon in the LAD, so we can do our first kissing balloon inflation.
Let's have a 27538 stent.
So would you go simultaneous inflation of the balloons or 1/1?
We'll do one by one, and then we'll do simultaneous. So we'll go first high pressure in each to make sure that the vessels are well dilated. So that's the LAD. Go down. High pressure in each. And I think that makes the balloons more sticky and less likely to slide once you inflate the balloons simultaneously.
Yes. So sorry, doctor, for asking. What is the point behind this kissing? Is it to optimization of any of the implanted stent or for the next one? What you are preparing for this?
It's basically when you want to cross, when you want to recross, it's better to cross through one struts. Okay?
Let's see that. Okay, 1, 2, 3, down.
Okay?
So it's important to go down together, and I wanted to make sure that's
Very good.
It's basically instead of crossing with the balloon. See, when we wanted to cross with a balloon and one struts, it was difficult. And you can imagine if it's 2 layers of struts. So that's to make it easier.
So the main advantage is to make sure that you can finish your procedure with kissing balloon inflation with both ostia being open and not covered by stent struts. So the stent, please.
Abdullah, Khaled,
So
we
now
have
we're ready to get the...
we have 8 minutes, so let's try to push for the. So you get the stent now.
Yeah. So don't ask us questions.
Yeah, sure.
Talk to each other. Stent, please. Yes.
Go cranial, please.
Epicranial.
So one of the benefits of using two stent techniques, and especially DK crush, is that the circumflex is now protected. You know, you can walk at your ease in the LAD, that vessel will remain open. So that is one of the reasons why this technique is being adopted, because it generates some sort of certainty that you will not lose your side branch after you have done this procedure. So
3530.
this is
33. 3533. 3538.
Well, Dr. Khaled, if you allow one question, or you are busy with...
Go. You can go ahead, ask us, we try to answer it.
Okay, I'll do that.
No, I'll not disturb you.
Okay. 12. Now, okay.
So we always deploy it not too high pressure because of edge dissection. You can pull it back and go higher pressure. Because you can just go up here.
Are you using some sort of co-registration with the OCT and the angiography?
Yes, we do. We have Alterion, and we have, well, it's installed in a different lab, the co-registration. Unfortunately, that lab is down today, so we had to use the lab without co-registration, but we still can use the Alterion. So we don't have co-registration today. Sorry.
Okay, the other stent ready?
An OCT at the end.
Ziad, perhaps you can comment on what is coming with Ultron 2 in terms of co-registration and this part of
Yeah,
it.
so there's a couple of very nice features on Ultron 2.0. That is, there's something called the dynamic angio, which is actually a stent enhancement. So you can zoom in on the stent in real time. You can advance your stent in real time and see where it ends up with regards to your markers. So it's a significant advancement on the current technology for co-registration. Not only that, the co-registration algorithms are now much more accurate. We used to get about 20% failures. Now that's down to about 5%. So there's some significant improvements in 2.0. But the dynamic angio is a major improvement.
So, Dr. Khaled, my question is the length of the stent in the left main LAD.
Tell me to the stent first.
Is it depends on the...
So
my question is,
What?
is it OCT guided, or you have, or you want to have enough space for pot, or
we covered this.
Abdurrahman, you want to say something? please?
Yeah, just the clinical part, because he's working on the stents. And this patient in this stage and going for transplant have two questions or to raise. One is the dual antiplatelets, for how long, and when to shift him to single antiplatelets, and then when to allow him to go for the transplant, 6 months, 1 year, or maybe after 1 month or immediate, and what is the advice for the antiplatelets?
Maybe I can...
Does he be advised to stop the antiplatelets both, or can go with for the transplant while in one or in two?
So maybe I can make a comment on this. So albeit left main PCI was excluded from Illumian 4, the one thing that we categorically showed that if you do an imaging guided PCI and get optimization, your stent thrombosis risk is basically eliminated completely. And so the risk, of course, that you're trying to do when you're dual antiplatelet therapy is to minimize your risk of stent thrombosis. So having run the cardiorenal program at Columbia for years, in this patient, this is the strategy we would have taken. We would have said 3 months of dual antiplatelet therapy because it's a patient with left main PCI. If the patient has a living related donor, we used to do a diagnostic angiogram before taking the patient. If the patient has doesn't have a living related or is going for a deceased donor, we reevaluate them on a yearly basis, whether it be stress test or nuclear imaging, etc. And because you're putting in big stents here, one thing you could do is you could do CT and be able to look inside the stents. So there's multiple ways to sort of evaluate that. But most importantly, I think the stent thrombosis risk is very, very much minimalized when you do an OCT-guided PCI.
So yeah, let me ask, there's an additional complexity in this case. It's a non-STEMI presenting with the culprit is the right. How would that change that the APT strategy?
Yeah, that's a good question because, technically we should be waiting for at least a year. But the most precious thing that can happen to this patient in terms of prolonging their survival is a kidney transplant by a country mile. So given the opportunity if the patient get a transplant, that has to take the priority.
Of course.
So if you add,
I think that's a very good comment there, that the kidney transplant is the fundamental factor that will prolong this patient's life and increase his quality of life. And informing patients beforehand on the treatment options and how and where it all connects, the dots have to connect together, is a very important thing. Thank you.
Remember, the CKD ESRD risk for restenosis is 88% higher than a conventional population. So you're essentially doubling the risk of restenosis, which is why your point was a very good one about medical therapy. Now, the truth is, there's no kidney transplant program on earth that I know that would transplant a patient with a left main lesion, unfortunately. So that's an additional complexity.
They would transplant those patients after a cabbage.
Oh, yeah, sure.
Yeah, definitely. Khaled, Abdullah, we have 2 minutes.
Yeah.
Tell me.
Let's show you what we have done. Okay, Simi?
So, would you just quickly explain to us what you've done so far and show us the final?
So what we've done so far, we're just taking some pictures now, just to show you. We put 2 stents, overlapping stents in the LAD all the way to the left main.
Beautiful.
And we have done the part. And now we are about to recross and perform our second kiss and then part, and then we are done.
Great. We have 1 minute with you, so you could show us if we can do the part at the end. And but really, so far the result looks beautiful, and I think you made things look much easier than what it is. So
yeah, Mohammed, this is very important comment. And geographically, usually when you do bifurcation stenting without kissing, it will look angiographically really nice.
Absolutely, you need to finish with proper imaging.
Kissing,
absolutely.
Yes. I don't know if you guys noticed the serve wire. I just recrossed into the serve, and I didn't use any skill at all because the stents was crushed nicely. So it makes your life so much easier when you do the steps properly, when you crush the stent using the properly sized balloon based on the OCT or IVUS.
100% agree.
so would you do imaging at the final, or you are happy with the?
No, definitely we have to do imaging.
Great.
You know,
yeah, it has to be done.
With left main PCI, you should not leave any stent unturned.
We have one final question from the audience because we are out of time.
Yes, thanks Dr. Khaled for this case. I'm Moyal Abdullah from Okasmi. For this case, usually with the Ultron, we have an 80% expansion is acceptable. But if we know that this case is going to stop his dural platelet early, would you go for higher, more expansion, like 90 or more? Do you think about that in this kind of cases?
Remember,
Is this a question
even
for us,
in Illumian 4, I was just going to say that 80% and 90% are all targets. Your limit of expansion is limited by plaque. So if you size your stent appropriately and you post-dilate with the appropriate balloon, there's no more that you can do. These are all sort of false targets, right? Whether you get 80 or 90. If you get to 78 and you've post-dilated with an appropriate size balloon, there's not much more you can do. Maybe we can just leave the last comments from the team from Kuwait.
Okay, thank you.
So, Abdullah, you're going for the final kiss.
Yeah, the 2O balloon is not going, so we're going to use 1.5 again. So these are the usual difficulties that you face when you're performing DK crush or nano-crush technique. So you should always be prepared that you are using a guide that's very supportive. Your wires are positioned distally so you have good support. Make sure you have small balloons. Now, some companies make even 0.7, 0.8 millimeter balloon, which sometimes can be extremely helpful when you are performing this kind of technique. So I think attention to I think a main learning lesson is, from this case is that if you want to do a complex PCI, you have to have good expertise with intracoronary imaging, know how to interpret it, how to use it to make your life easier, and the importance of following the steps without any shortcuts.
100% agree. Abdurrahman?
Yeah, for the balloons, since we have the stent and we have the two balloons, so why not to advance the 4O or the other, the LED balloon to the stent and inflate it to the nominal or subnominal or whatever, and to anchor to cross this one to save the time to cross, because downsizing the balloon is not safe.
That's a good point. But sometimes you want to feel the resistance because the wire might be behind the stent. So you don't want to force it. So if you're having a lot of difficulty, that might be a sign for you that your wire is behind the stent. So you have to be careful when you do that.
So, Khaled, Abdullah, you're going to finish with the final kiss and then you're going to do some imaging?
That's the plan, yeah.
Yes, so what we're going to do, I think we'll do more post-dilatation to the LAD. We'll do kissing to the bifurcation part, and then we'll do imaging, see how much expansion, what apposition, and if we have edge dissections, which is to finish the MAX algorithm, and we'll be guided by that.
So I liked your summary. The take-home message from this case is clear. You need to know and be familiar with proper intracoronary imaging and know how to read it and interpret it. You need to set up your strategy and know exactly what strategy based on the complexity and reading and interpretations of your coronary imaging. And you have to go step by step and never go for a shortcut, and be consistent and persistent. So that's always the case. And finally, you need to do your final case spot and do the proper imaging before you walk away. And thank you very much, Khaled to Abdullah, for a great case. You really made it looks very easy, although it's very complex. And thank you very much.